Multidisciplinary management of patients with GIST is really optimal. This requires good communication between the surgeons, the pathologists, the radiologists, the medical oncologists. We accomplish that often by multidisciplinary tumor boards where all of the GIST specialists meet together in one room to go over a patient's case from all of their individual expertise, such that at the end of the conference we have a plan in place that takes advantage of published literature and our individual experiences that give the patient really the best chance of surviving the longest from gastrointestinal stromal tumor. The nurse and the nurse practitioner are critical members of the multidisciplinary team. The nurse and nurse practitioner may be the first one to get a phone call from the patient who has developed a toxicity. For instance, if the patient has developed hypertension, the nurse or nurse practitioner may be able to call in an antihypertensive agent such that the hypertension doesn't get out of control and the patient doesn't have long-term toxicity from hypertension. GIST patients are often co-managed by a community oncologist and a GIST specialist at an academic center. This co-management is critical because at the academic center we have a multidisciplinary GIST team that can help delineate the treatment plan at the time of diagnosis, ensure the correct diagnosis, and determine the appropriate therapeutic options and monitoring going forward. After the patient has been on therapy for some time, the patient may develop resistance, and referral to a GIST specialty center could help determine whether there's a clinical trial available, a new agent that might make sense for this patient. Referral to a GIST center also allows in-depth mutation testing of the patient's tumor. This is critical because GIST now really is a category of 9 or 10 different types of GIST that are characterized by their individual unique mutations. The most common mutation is the gene called KIT, which we treat because it's sensitive to imatinib. However, if a patient has another common mutation, such as PDGFR D842V, that mutation is generally resistant to imatinib and the patient should be referred to a GIST center for a clinical trial. There are other rare mutations, such as RAF, PI3 kinase, which could be treated by an alternative targeted therapy, such as a RAF inhibitor or a PI3 kinase inhibitor. And then there's this type of GIST called SDH deficient GIST that is much more difficult to manage, and we're really starting to try to understand it at a biological level. These tumors may be more sensitive to a medication like regorafenib rather than imatinib.